So nowadays we have 4 JAK2 inhibitors. This is a nice review from Dr. Masarova in Blood recently, how to treat and how to individualize the selection of the JAK inhibitors in this era. I think, obviously, as I mentioned, first we establish a diagnosis, we risk stratify the patients. If we are thinking of transplant, we start rolling the ball for transplant. And then we ask, are the patients symptomatic or not? A very early stage, low stage, grade, asymptomatic patient observation is okay in those patients. Then, I try to put the patients almost into 3 groups. Splenomegaly constitutional symptoms, which most of the time go hand to hand, predominantly just cytopenia, or they have splenomegaly constitutional symptoms and cytopenia. And the choice of therapy is really based on that. So if patients have splenomegaly proliferative symptoms, we go ruxolitinib first line, probably fedratinib second line. If patients are predominantly thrombocytopenic, I think pacritinib is the treatment of choice, especially by the FDA label if they are less than 50. Sometimes even in the group 50 to 100, if we know that we need to get to a meaningful dose of treatment, we may go with the pacritinib choice. And if patients are anemic, momelotinib is the probably preferred option. Pacritinib can be an option as well. And obviously, during the patient journey, we are going to kind of alternate or change those. So you have to think also of the sequence of therapy and how to optimize the use of the JAK2 inhibitors. Historically, when we had data only on ruxolitinib, we were saying ruxo failure, the survival is around 12 to 14 months. The group from MD Anderson published the data from their clinical trials. We published on real-world data, and we both had almost exact numbers, 12 to 14 month survival after ruxo failure. I think this is now changing a little bit because we have fedratinib, we have pacritinib, momelotinib, but after more than one JAK2 failure, actually it becomes even more challenging, and the survival and the outcome for those patients is getting poor. So it creates an unmet need where we need really to get more clinical trials or also introduce new combinations, which you'll hear about from Dr. Mascarenhas, to try to improve the durability or the percentage of patients that respond from those treatments.